So now let's move on to the discussion. Let me call the three speakers. And after the discussion, we will ask you to stay a little bit more. Anouk has something important to tell you. We had three great interventions, high-level presentations, and I think that this will have your brain boiling and that there will be many questions from the room. So who wants to start? René. My question is for, René Cassou. I have a question for Anna. Anna, you showed that there were variations from inter-individual, but are there variations of intra-individual? Thank you, René, for your questions. Yes, in fact, that's the next chapter. But what we showed is that by raising the notion of signature, what we showed was that based on the data we have, there is a stability, intra-individual stability in this gaze behavior in typical and in ASD behaviors. And the reason why we did this is that we were preparing an eye tracking paradigm measurements to be applied in an intervention protocol. And we needed to have this information. That is, are the measurements that we make of social perception, are they stable over time, or are they variable over time? Because if they are variable, and if we do an intervention and we make measurements before and after, we cannot say that these. Can we say it's due to the changes are due to the intervention or fluctuations? And with the data that we have, we were able to show this stability, very little intra-individual variation. Second question. So this variation of the gaze is a biomarker for social interaction. Does this translate in the behavior? For instance, as a score on the ADOS, does it show a good or average correlation? In the framework of autism, a very good question, because we sort of, have cutoff points for behaviors. But is this something that is generalized? Or in the case of autism, it was shown and reproduced that these social gaze behaviors are correlated with the severity score and the ADOS. The more you have this social gaze behavior, dysfunctional, the more dysfunctional it is, the more severe the symptoms of autism. In the case of neurotypical development, we also try to establish a correlation with this behavior of social gaze behavior, and back then with IQ, but we found no correlation. So maybe the relationship is less direct, with less factors that intervene in this. No, we didn't find this correlation. So to bounce back on what René was saying, what you showed is a nice image of neurodiversity with all the things related to things that are specific and what's different, and the overlap with namely variability with human operation. So this is not something that we see that in our clinical practice, but when we fill out questionnaires with grids where we have to fill up characteristics, do you have other groups when you see the images? Children with an ADHD must have difficulty maintaining their attention on the face. So for the moment, we don't have the control group. So we were not able to see that with children without autism. The pattern of eye tracking will be impacted, but that's not necessarily significant of stimuli with a social content as opposed to autism. But what we're going to develop, we are putting in place with Hélène Glusser a study, a research in women with autism, and who come to consult for a diagnosis which is not confirmed, but they have other difficulties. So we have planned to have scores and imaging and attempt to identify patterns that are specific to women. But actually, there are not many studies or data specific to women. And we are also interested in identifying intermediate patterns, which would enable for us to identify adult women, and it's more complicated. So if you have questions, I have a question for Dr. Gressens. Thank you very much for your presentation, and especially for the final message that is related to the other presentations on the need to have the detection as early as possible. In Montpellier, we have a cohort with pregnant women who already had a child with autism, and given the genetic factors, risk factors, 20% will also develop an autistic disorder, and we want to improve our knowledge to have a detection, earlier detection, and to prevent the onset of autism or the development of autism. And my question on the endocrine disruptors, they are described in their relationship with autism, but when we talk about which hormones are involved in the relationship with endocrine disruptors. Thank you for this very relevant question. And of course, we have a major focus on this. They're called, endocrine disruptors because the first thing was that they were demonstrated to disrupt the endocrine functions, namely the hypophysis axis. So somehow a bit far from the brain itself, because endocrinologists do not speak to neurologists and vice versa. But we know today that inflammation, stress, and all of that, and this raises questions, it seems, in the room. And hormones, stress hormones, inflammation, all of that, communicate. And it's kind of, it also speaks a little bit like the microbiota. If your digestive tract does not really doesn't work, you seem maybe to have a brain fog, and this is not just a delusion. There is something. So the idea that these endocrine disruptors are also brain disruptors to some extent. If a molecule can disturb hormones, it can also disrupt neurotransmitters. It's kind of a vague answer at this stage because we are not really yet there. There are lots of, not many papers focus on the endocrine, many papers focus on the endocrine disruption problems, but not so much the brain disruption. I'd like to ask a question to Giacomo. We saw publications on major groups with early intervention, and the conclusion was that the effect was, well, not that striking. and some persons in France took this kind of publication to vindicate that, well, you know what, it doesn't work. So it's useless. But in your expose, you showed that different responses are related to different factors. How could we argue that against these people who really will want to say, you know, you put a lot of means for early intervention, whereas it's useless? What kind of message can we oppose to that? And also, how can we, you know, take care of the subgroups? Because not all children do not all respond exactly to this or that approach, as you showed.
Thank you for this great question. So there are two issues. One is measurement, the way we measure intervention effects. It does not capture some of those very crucial turning points that for some children means life-altering changes. Learning how to do one thing, such as, for example, approaching other children in a way that does not scare them, for example, and just making one example. Or touching someone on the shoulder to request their attention instead of, for example, getting very frustrated because the person doesn't give attention. Those things can change the life of a child because other individuals around them will be more inclined to interact with them. And this is the kind of small thing that is life-altering for an individual, but it's not captured when you look at the traditional outcome measures. It also boils down to what is the intervention designed to achieve. And I think a lot of the debate that there is in autism intervention is about the fact that, well, it's supposed to change this, and this, and these other outcomes. The child is going to be more flexible, more sociable, more communicative, a lot of different outcomes. And it needs to be clear when we enroll a child in an intervention, what is it exactly that we are trying to achieve? And sometimes our measurements are very generic. We're looking at things that are just not subtle enough. The other thing is that what you're looking at in the results of a trial is the average change of a group compared to another group. And this comes with two problems. First, more and more children in so-called control groups are also receiving an intervention that often is pretty good. And so when you see an intervention that used to have an effect and then you do a replication and the intervention doesn't have an effect anymore, sometimes the change is the same. It's just that the control group now has also improved. That's good news. It means that the treatment as usual has gotten better, certainly better than the times in which Ivar Lovas was doing his first trials. So that's good news. It's not bad news. And the other component is that what does it mean for an individual? If I'm an end user, I'm more interested in what is the likelihood that my child is going to learn or advance in whatever skill is important for me, as opposed to what is the average change in the 50 children or so who did this intervention. So it's not useless, but it can become useless research if all we care about is whether there's a statistical significant difference between a group, an intervention group and a control group, without thinking about individual differences and what was the control group doing.
So thank you for this excellent presentation and for the avenues that you showed us that we need to explore I also do a lot of eye tracking in Bordeaux on diagnostic aspects, but this is a tool that is not yet much used in that framework. We hear a lot of eye tracking for the newborns, the little ones, and this is something that I've had in mind for a long time now. Your intervention enables you to move out of the diagnostic framework and go toward profiling. She's going a bit too fast. And with autistic children and non-autistic, my question is, do you, I think that the children you have in Philadelphia are between 6 and 8, and I think that these are children who came in the area of comorbidity of the ASD. Do you also monitor them longitudinally to see these different profiles? Is it possible to capture these NDDs that will add on the more these children grow? That's my first question. Do you have longitudinal studies for this profile for these children? And my second question, which is associated, is do you also have projects for integrating in your team a very early profiling, including eye tracking, but for an indication, therapeutic, not diagnostic indication?
Thank you for these great questions. We are part of a multi-site trial of a new technology that was designed by Amy Klein, who was mentioned before, where we're looking at eye tracking, the sensitivity of eye tracking in response to treatment-related change. So can we use eye tracking to determine the amount of change in response to intervention? I'm pretty agnostic about it. I was asked to evaluate that in children who receive intervention, and that's what we're doing. We're looking at the concurrent validity between change in eye tracking and change in behavioral measures. It's a potential avenue. In terms of longitudinal, I will love to be able to see these children who received our intervention for 1 year at multiple time points. It's extremely complex logistically. It boils down to funding and whether you can claim that that you need additional resources to just follow up participants who are no longer receiving interventions. And until now, we were not able to get such funding, but it's important.
I know you, but I'm Kathy Lord. I have a question, I think, for Giacomo, but also probably for you, and maybe not so much for endocrine. But I think one of the things you talked about was the individual differences in the kids, which you found from eye tracking in other ways. And I think my question is sort of a policy question of when do we get that information? I mean, we were talking last night about speeding up waiting lists, getting faster assessments. I feel like we do get that information, not as good, but for an ADAS, I can say, oh my gosh, this child imitates with objects. He doesn't imitate without objects. He's always looking at my face. I can't get him to look at the object, or he looks at the object, he doesn't look at my face. And that builds what we recommend for intervention. But often when kids get into interventions, they aren't asking us what we should do. And when they get to therapists or teachers, the teachers don't have time to think about, oh, this and this and this. They could, but that isn't often part of what they're given time to do. So where does that happen? That's my question. I think relevant to your work too.
So we think a lot about that. I think there's a missing link in the process from diagnosis to intervention. So when we started our program, we were giving parents a very long report, and they had a lot of information. And then we learned that then when parents were receiving interventions, if it was a clinical intervention, the speech and language pathologists and also the ABA providers, they were redoing their own assessments that they liked more. And none of the information that was there in our reports was clearly used by the next by those who could have benefited from that. I don't know how to change that. Some of my colleagues, including Deb Fine at UConn, are advocating for different paths for those who have so-called frank autism. That is someone who it's very clear that the person is autistic, and maybe their argument is that, well, you don't need a very comprehensive process of assessment because it's very clear what the diagnosis is, but the point is that then you lose that information that might be relevant for profiling or for directing to the right intervention. So I will be in favor of learning as much as possible from the child, but somewhat finding a path to accountability so that the information becomes relevant, to informing targets and strategies. But I don't know how to do it.
Merci.
Thank you, and this is a very good question. It's a very good question because it is true that for me personally, in our lab, we do not we're not too related to clinical practice. In my case, we see the children in the research setting. They come, we do eye tracking, MRI, but we don't have necessarily a feedback. But what we do and what we have always done, and I think it is, and it has much value, is that we give feedback to the parents, because eye tracking is known today. 10 years ago, 15 years ago, when we started that in France, it was not really well known. But we show the parents the recording with the child, and the reactions to that can be really quite moving, because the parent can see, well, my child has a gaze focused here, not elsewhere. This is what my child does or looks at. And this feedback for families is precious. And beyond that, I think that the Emmy-Clin does great work on eye tracking to try to make the method more available. It's a powerful method. It does add clinical value. I don't know what Dr. Giacometti introduced today, but this type of profiling has this negative connotation, but I think that this finer characterization of the profiles of children who will act behavior this or that way and who might benefit from this or that type of intervention is, I think, something that we all go into the direction of this personalized medicine that will be of benefit to families and children. No doubt about that.
Hello, Christina Nikolaidis. I'm a professor and physician in the United States. This question is primarily directed to Dr. Vivanti, but others perhaps as well. And thank you. That was a wonderful, wonderful talk, and very interesting work you're doing. I was intrigued by some of the slides at the end that you didn't have a lot of time to get into regarding the kind of changes you've made to make your intervention more neuroaffirmative. And I understand that some of it is to potentially, prevent negative things on TikTok. But I'd like to hear a little bit more about how these changes have affected not just the image that might appear to TikTok influencers, but actually to the mindset of the clinicians that are giving the intervention and the families that are receiving the intervention. I say this because my personal experience is that I had many wonderful positive twists of fate. When my son was originally picked up and put in an early intervention at 2.5, he would have been in that group of the minimally verbal kids. And by twists of fate, he happened to get an intervention that was well matched. By the things you say, it was perfectly well matched to what I can imagine his profile would have been at 2.5. We had many, and he did respond extremely well. Not that that mitigates all challenges in life, I can attest, but certainly responded well from these markers. But another twist of fate was that when he was very, very young, I did get influenced very much by adults that were in the autism rights movement. There was no TikTok back then, we're talking about the early 2000s. But that influence wasn't just in what I chose not to do. It was really changed how I raised my child, not just in the hour of therapy, but in the 24 hours a day, and how I approached him and how I thought about him and how I responded to particular, challenges, how I taught him to think about himself. And that was exceptionally influential. It really changed my life as a parent and my experience of what it was to be raising an autistic child. So I'd love to hear more about what actually changed when you did this, and what have you noticed in your clinicians and in your families?
Thank you, Christina. And I do apologize for rushing towards the end, and I do it all the time, and I never learn. It happens all the time. So this is a process, and the first point I want to make is that I don't know if the way we are now doing intervention is more neurodiversity affirming. That will be established by the end users, and that is part of the research cycle. But we're trying to question the way procedures were originally designed through that lens, and with the help of those who are directly, not just those who are stakeholders in different ways, because we listen to neurodiversity advocates, but also, for example, when we talked about the work of doing this in a daycare, we listen to the teachers a lot, and we realize, there's so many constructs that are relevant for these teachers who are not in the ESDM book. That's why we had to rewrite another one. So there are multiple stakeholders. Issue number one, we're working with our colleagues at Drexel to operationalize the construct of neurodiversity affirming. I think different people use the terms to mean different things, and I don't want to put that label there as a badge of sanctimony. Okay, now I reached enlightenment because my colleague Eva or Dina gave me the stamp of approval. That is not what we're aiming for. What we're aiming for is thinking about the design of this. For example, joining a child who is spinning a ring, and then expanding that activity so that now the child is also doing this playful mouth movement. Is this something that people see in contrast with what they will intuitively believe is in the best interest of that child? And that is where we basically are rethinking this and say, okay, well, this makes sense because of that, and this is what we're looking at, social learning. Social learning is different from compliance. So now I want to make a distinction between achieving engagement and achieving compliance. And then the next thing that I believe is consistent with this message is to acknowledge, and this might not be working for everybody, and this might not be helpful for all children, and it's in their best interest that I say that, and maybe that I don't do this intervention for children who have a different preference, and introducing this concept of preferences. Everything that you saw there in those videos was based on highly preferred activities from those two children. You do it with another child, it might be a torture for them. So we need to be responsive to that. I think we need to stay humble, and I think the one thing about the TikTok influencers is not so much whether the content is aligned with some evidence, but how confidently and how radically those statements are made and how much they can influence one person to close doors that are potentially life-changing for a child. And this is the same for everything from vaccines to any choice that you can make. So I don't know how to counteract that, and I don't want to make every TikTok influencers as the villain, but it is concerning that decisions are made on quick statements rather than complex reasoning. That's my fear.
For me, I wanted to get back to the question of efficiency of the interventions. Just thinking that administration of the evidence is impossible. You know, we cannot do double blind. We cannot have placebo for everything. We are in a situation that looks like that of the what we call instruction. Can we prove that it is important to go to school, to go to high school? Nobody is trying to prove that, because behind this there is a requirement, cultural requirement, references to special interactions with your environment that leads us to understand each other. So I think that asking this question is maybe risking to go on the slippery slope of the importance that it might have for families first and for the persons themselves, that we can address specific aspects of their problem, addressing the question of well-being, for instance, which is so important. And also we have an indirect administration of the proof or the evidence with the external, not internal, like children who were refused at school and now they go to ordinary school. So that kind of story, will have a lot of them every day. And some people say it's a spontaneous development, but here again, because we have no placebo, we have no comparative elements, these are questions that we really could get drowned in. So I think these questions should not be relevant to the discussion, because we should stop asking them. I was really happy when I saw Giacomo on the floor rolling with the child, because it meets the kind of work that I do with nonverbal children. Of course, we work a lot with the body in our imitation, not so much with the learning with objects, but we work with thought without language, and everything that motricity and motor cognition enables these children to move forward. For that, we have strong arguments in favor of saying what is motor cognition and why is it useful, what kind of mentalization it enables. In the absence of language, we need to cultivate that aspect. On this, we have strong arguments in favor of what we do, even if we'll always meet people who will say, if you'd let that child, have an autonomous progression, he or she would have developed language. But you know what? Let's reassure ourselves by the fact that what we do is very useful, and it is not against everything that was said this morning, and namely by Professor Gressens on the elements that are basic elements that are the foundation of all our work. So I think that we should be proud of what we do, because it is very useful. So, if I may, thank you, Jacqueline. This just makes sense. It's so clear. So let me say something a bit controversial, because we have limited means, like in most countries. If we don't bring evidence of some efficiency, public powers, the authorities will hit us on the fingers and say, it's very expensive, is it worth it? It's really not to challenge what you said, because what you said just makes sense. It's so self-evident. But we have to talk to people with a different kind of reasoning. When indeed I participated in work groups for recommendations, where you have people who follow up or monitor these major publications, where you have no subgroups, and these are the people who speak to the decision makers, and they say, well, you know what, that's useless. This we know. I agree with you. We know, but some of our interlocutors need convincing based on evidence. I had a question, just a laywoman question to Dr. Gressens. I was very interested in the level of detail that we are going to demonstrate the risk factors in prematurity, because it's been a few years now that prematurity is a risk for ASD, but we also saw that there were other factors that will compound prematurity, and the risk becomes really major. So this type of information, does it reach the clinicians, to pediatricians in neonatology, and all these people who could try to influence the factors that combined with prematurity can worsen the outcome and the path? Thank you for this very central question. And here we loop back on this question of centers. This is very dependent on the centers. It depends on the communication between, with OBGYN and neuropsychiatrists and pediatricians. And it's a whole chain of specialists who should speak to each other. It does not necessarily exist in hospitals, because people, not that they don't want to speak to each other, but they're just sometimes too far away from each other. So it's something that has to start in the prenatal period, and things get, play a role in the perinatal, around birth. And the difficulty is that we have several specialties who intervene during a small period, but these people need to get together and speak together and exchange the information. Many things that happen in the first trimester will not be transmitted to the neonatologist. You know, some infections that occurred in the first trimester, it is never transmitted to the neonatologist or the pedopsychiatrist. But maybe the electronic files will improve things. But it's maybe this is the future state, but we need people to speak to each other. The notion of separation between obstetrics and pediatricians. Once the baby is born, no longer my problem. Before the baby is born, not yet my problem. So we need to have a chained link for the child from conception to, out of the womb and growing. So we need to have a collegial approach. One last question.
Hello, I have a question for Giacomo, but also Anna. I love the idea again of variability and inter-individual differences. You talked a little bit about modifiable factors, but we know that there's variability, as Anna also mentioned, in other ways. It could be genetic. So I guess my question, very short, what role does biology play in intervention outcomes? And are there studies that have tried to link, say, genetics with, like, maybe those are the kids that benefit the most, or looking at things like ERM, or I mean, we talked about eye tracking, which is kind of a proxy of behavior, but more like, say, non-modifiable, like, connectivity, for example, or things like that. I'll be interested in knowing.
So this is an excellent question. There is some emerging line of research. For example, my colleague Mike Lombardo, together with a consortium, a separate consortium, looked at some genetic factors that seem to be associated with response to intervention across a variety of interventions. So it might be that future research will be able to map specific biological components to intervention outcomes. I think what's important, though, it's always to think about the interplay between those factors and all of those different layers, the individual's experiences and preferences, the family, and then services and supports, and then policy, and then the general cultural attitudes, all of those things. There's an interplay between all of those things that is often neglected by research or understudied. And reality is that you might have a biological factor that puts you in a very positive trajectory of learning and opportunities. But then if the society doesn't provide those opportunities, it doesn't really matter. If services are not accessible, maybe because of your demographics, for example, then that biological factors don't help a lot. So the risk of putting the lens exclusively on biology is that we fail to understand how the experience that comes from all of those different factors is going to ultimately affect your outcome.
Thank you for your attention. And now let's move on to a next sequence. Anouk is going to speak to you. Okay. You're going to be disappointed by what I have to say. It's just housekeeping rules for this afternoon. Kathy Lord at 2:30 this afternoon, and interventions will start at 3:30. And I am now going to hand over to our host from Port-au-Roch so that they can thank them for their welcome. Let me hand over so she can introduce her team. Thank you all. I am Marina, the director of the domain, and let me introduce the team. We have the housing, accommodation, Laetitia, Cathy, Wana, Christine, and Sandrine. We have Marguerite and Sophie. The team is not all here. The cuisine with Bryce, Frank, Francis, our chef David, and Ellen, who is hidden somewhere, Tanguy, Simon. We also have the restaurant, Fanny, Nelia, Kevin, Fatima, Thierry, Daniel. Some I have forgotten. So the maintenance guys are not here, and the team is not fully here. We hope that we have contributed to the success of your symposium. Thank you. I'd like to thank you for the quality of your work and your patience. Thanks to all the teams, the restaurant service, and I'd like to thank the the team for housekeeping of this room after we have moved the chairs around, and thanks to the maintenance team as well.